Hi, my name's Eli Silber. This is the Multiple Sclerosis Academy, and we have two excellent speakers talking about breathing, about speech, about communication, and about feeding. I think in really important areas, particularly for people with more advanced multiple sclerosis. I think that our colleagues who manage patients with motor neuron disease and other degenerative conditions maybe have more emphasis on it, and we as an MS community should perhaps be looking at this in more detail. Two speakers. Jodie Barber is a neurophysiotherapist based mainly in Hertfordshire, but also spends a day at the National Hospital for Neurology, is passionate about breathing and control of breathing. She is co-chair of TIMS, the therapists in MS who've done so much working with the MS specialist nurses to bring forward MS care, and is very keen on doing this. She's also a yoga teacher and breathing instructor, and I'm sure we'll be able to add to that. Jodie, over to you.
Thank you very much for inviting me to talk. Yeah, it's a topic that I'm really passionate about. They're my disclosures. So I think some of you may have heard me talk before because this topic's popped up a few times, but if we think that there's a slide here that explains that about 47% of all deaths, I think the percentage is probably a bit higher. I don't know, that people admitted to hospital respiratory complications, but it's certainly up there. It's certainly high. But really, today is about when we might start intervention, when we might start being worried about this, and why, what's happening. So we'll be talking about aspiration, atelectasis, which I find hard to say, pneumonia, and these can all end in terminal events for people with MS. And it's about what can we do to change that trajectory and minimize this being a terminal event for someone with MS. And I think there is an awful lot that we can do. There's a hyperlink on there. It's not the one I meant to use actually, but it's quite an interesting article that looks from patient safety, which looks at healthy years lost. The data for healthy years lost. It's actually one about pressure sores, but apologies to put that on there, but it's really interesting information. And I think it's about how can we increase and how we can gather data about healthy years, increasing the healthy years for our MS patients, as well as preventing untimely death. So when do we monitor, assess, manage this? At the point of diagnosis, this is something we should be worried about. When things start to deteriorate after chesty cold or infections, or at some point between the two, or an EDSS over 7, because we know that many breathing problems are that people don't come to me saying, I'm worried about my chest. That's not what they come to me about. And I don't know what you guys experience. So I just want you to think, and this might, we'll cover some of these questions as we talk and at the discussion point at the end. So this is a real whistle-stop tour. I'm just talking for a short period of time about respiratory dysfunction and what the problem is. But what picture starts to evolve in MS? Well, often what I'll see as a physiotherapist is immobility and reduced muscle strength. And over time, that can result in stiffness of the trunk and the chest wall due to loss of range of movement. And alongside that, you've got your lungs inside your thoracic cavity. You're going to have loss of lung volume. And atelectasis, I can never say that very well. What is it? So what it is at the end of our bronchial tree, and always think of my bronchial tree a little bit like a piece of broccoli, and those very tiny bobbly bits of your broccoli at the end, they're your little sacs, your little air sacs where the gas exchange happens. There's thousands and thousands and thousands of them. And in order for them to stay open, they need to stretch. And the most potent stimulus for this is production of surfactant. And so the thing that keeps your alveoli open is the surfactant, but the most potent stimulus for the production of the surfactant is stretch. That's taking a big deep breath, and that maintains that lung compliance for gas exchange. And I think what we're seeing from very early on, the minute that you are starting to get immobile in your trunk, some weakness, then you're not getting that maximal stretch in all of your alveoli and reducing your opportunity for gas exchange. And the reason I've kind of banged on about that is when we breathe, we create the optimum conditions for health and well-being. And when we don't, we lay the foundations for illnesses such as heart disease and blood pressure and chest infection. It's why I'm so passionate about the breath. I'm passionate about us all learning to breathe well, because we can all optimize that gas exchange in those little air sacs at the end by learning to breathe well, improving our motion. And lots of physios say motion is lotion. So what I think is, the more you take a deep breath, the more you're going to get that surfactant lotion going on in those little alveolar sacs at the bottom. And this is the point that I want people, I think it's important to educate, this is my personal view, people from the point of diagnosis by breathing and maintaining your respiratory health for all of us is good. So for effective protection against respiratory tract infections, we all need to cough. You can have a good cough now if you want to. But it clears the excessive bronchial secretions and inhaled substances. And we have quite a lot of saliva. I don't know if Sheridan's covering this, but I'm always surprised, 1.5 litres of saliva a day that we've got to deal with as well. Our cough can be voluntary, involuntary, and the muscle groups are needed for this normal cough or your muscles for breathing in, inspiration, expiration, and bulbar. So there's quite a lot. And in MS, any of these could be affected. There's a link here for the consensus document, and this in here is the body of work that we tried to pull together in TIMS, and I think these slides are available to share afterwards. So I'm going to refer back to that. So I've just popped that there. Next slide, please. And in this consensus document, we have RAG rated ideally what we might need to do when, and I've really highlighted the consensus for early monitoring, for annual review of everyone from the point of diagnosis. Shall we just start doing a peak cough flow? But what do we do with those numbers? What do we do with those figures? So these slides here, I'm going to, for the next 3 slides, explain what to do. So at the beginning, where we've say got a peak cough flow above 270, you will want to be looking at general exercise advice, breathing education, etc. And if they're approaching 270, really wanting to make that a priority, but whether that's singing, deep breathing exercises, or whatever. I'm going to flick onto the next slide. When the peak cough flow starts to reduce a little bit more, between 270 and 160, then you might want to be thinking about increasing some added interventions like lung volume recruitment bags. We've put here swallow assessment and etc. You might even want to, obviously that might want to consider that earlier if there is a concern there. But timely referrals, you might be thinking a little bit more now. So this is someone who really is, they've got a weak voice. You're quite obvious that they may have reduced chest expansion. They may have already had repeated chest infections in hospital. And this is where we're thinking a little bit more about manual assisted cough, considering referral for sleep studies and cough assist machines, etc. But I'm going to flick on to the next slide. So those 3 slides I went through really quickly, just to go through that we've got some really this document that there's a link to has got some really is a digital document. It's got quite a lot of videos on how to use a lung volume recruitment bag, how to do a breath stack, how to use a peak cough flow. So it's a really good resource. It's available on the TIMS webpage. We've pulled everything together and when to. Okay, it is a working document. Any feedback's really welcome. We haven't got everything perfect on that. But the bit I want to spend some, that's just to reflect that there are other things we're also considering in the background as well. So I wanted to just focus the last few minutes of me speaking on 2 different case studies of people that I've seen. So person A has an EDSS of about 6. They're walking with a relator indoors, front door to car, independent with all personal care, stairs and driving. They've got some mild weakness developing their upper limbs. They're finding it more difficult to hold the trunk upright at the end of the day. And they've reported that holding cutlery, they can feed themselves, but it's a little bit harder. They've said they're not able to throw their voice as much when they're tired, or they're feeling like, they're a bit quieter in social situations. They've got no history of chest infections. What would you do? Are you concerned? And then there's person B, who's got recurrent unplanned hospital admissions. Chest infections, they're admitted every 6 weeks. and they've got spastic quadriparesis. The ward speech and language therapy bedside assessment at each admission report their swallows are normal, but they're losing weight. They've got a weak cough, inability to speak in sentences and only able to say one word and it's barely audible. They've got pressure sores that aren't healing. And I do know in this case, they had a peak flow between 50 and 100. So you might be thinking, what do you do? I don't know. You might all have different approaches. Started with person B. He was admitted to hospital in the first peak of the pandemic and contracted COVID-19, ended up with a 3-month admission. I reached into the hospital to to support the inpatient staff with how they were managing all of his complex needs. And they did eventually video fluoroscopy him, and this revealed silent aspiration, all textures. He was immediately put on nil by mouth and a rig was inserted. Prior to this, the year prior to this, we had many discussions about feeding in alternative ways, tube, and he was not really up for that. But at the time, we had many conversations. But at the time that he was presented with this, he was able to consent to the rig because we'd had those much earlier conversations. Now he has no more chest infections, but his lungs are chronically inflamed. He's got a continuing care funding application. He's got a really good team of people to help support him with living at home, including a care package, including RGN nurses. We couldn't get a cough assist for him, but he uses a lung volume recruitment bag 4 times a day. We've optimised his wheelchair and bed and postural support. He's got intrathecal baclofen pump, which help him with managing the spasms. And to date, he's had no more hospital admissions. He wasn't really that bothered about rig or, breathing. He wanted to get back to his football matches. Every time I call him up for his annual review, it's like, how are you? Yeah, still managing to go to my football matches. No more, no pressure sores, no more chest infections. So that's person B. Person A, so they were the person with they're walking, hands when they're a little bit weak. And I was thinking, they're already doing some breath stacking, breathing exercises, but decided to monitor their peak cough flow for 2 weeks at different times of the day. And they were about 270, 300, but we were noticing a bit of a dip in the afternoons. So we started a course of one-to-one therapy sessions focusing on upper limb strength and trunk strengthening. Also did a lot of normal breathing exercises with them to help with normalizing their breath patterns as well. And they started an online singing group, breath stacking exercises. We did introduce a lung volume recruitment bag. They were really interested to try this. And I monitored this, and now they're feeling, I use a modified fatigue impact scale with them. I just thought, let's just find out what, if there's any change. Fatigue is one of her big areas. And she's noticed that she is less fatigued. She feels she can throw her voice more for longer in social situations. She's more motivated to go out and socialise. So I'll leave over to Sheridan now, or to Eli to introduce Sheridan.
Thank you very much. And we're going to, we've decided to have the talks fairly quick so that there's quite a lot of discussion at the end. And if you don't mind, what we'll do is try and keep as many of the questions to the end. And what I'd really like is a discussion between Jodie, Sheridan, and the audience. I'd like to be also taught later on about lung stacking, which I don't unfortunately know very much about, to my embarrassment. Sheridan is an Actividian, but comes from Australia, which is a slightly less good rugby country. She's a highly specialist speech and language therapist based in the community in Surrey Downs, very committed to her patients and to their communication. I'm going to pass you over.
Thanks, Eli and Jodie. So we're going to be talking about swallowing difficulties today in MS. So firstly, the prevalence of dysphagia in MS is around 43 to 45%, which is quite high. And it's not always, reflected in the referrals that we get to speech and language therapy, which is a shame because it sort of does directly correlate to, early diagnosis and good outcomes. So definitely having early referrals is very much needed. So chewing and swallowing involves the coordination of a number of muscles in the mouth and throat, including those which protect your windpipe when food and drink pass through your throat. these muscles can be weakened, or the coordination of their movements can be disrupted by damage to the central nervous system caused by MS. So this can also affect the way that you sense the presence of food and drink in your mouth and throat as well. So early identification of a swallowing difficulty can be recognized by these signs, and these are things to look out for if you're thinking of referring: choking on food and drink, coughing during or after swallowing, coughing or vomiting up food, having a weak voice, aspiration or chest infections, excessive saliva or drooling, difficulty chewing, trouble moving the food to the back of the mouth, and food sticking in the throat. So I just thought I would show a referral form that we often share with our team and the surrounds. The top few items are what we call red flags. So if your patient has one of these things, then I would definitely refer to speech and language therapy for an assessment. The following ones in orange that start with nasal regurgitation and down to sounds of respiratory difficulty. If you have two or more of those signs, then I would refer to SALT. And the bottom three in green are more things that might be solved by speaking to the GP first. So that could be like a urinary tract infection, or just a dry cough that's happening when the person's not eating or drinking, or reflux, signs of reflux. So this is a little bit about what we would do on our initial consultation. We start with a thorough history, case history, building report. We're trying to discuss the medical background with the patient, and we like to get a real understanding of their likes and dislikes and what their lifestyle is like. This is so important with our MS population. As we know, families, work commitments, and quality of life are optimal and should definitely be considered from the beginning. We do also just check that respect forms are in place, ascertain if there's power of attorney, identifying family and friends, because as eating or drinking is something that we usually do with loved ones, it's good to know. And furthermore, family often do cooking or shopping, so they often play an integral role in carrying out the logistics of sourcing and preparing appropriate foods. We check positioning. This can mean whether the person's eating in bed or in an armchair, if there are any allergies or dietary needs. One other thing we start to try and identify is asking about fatigue and finding out if there is a pattern to it. For example, does the person have a 4 o'clock slump every day where they feel very fatigued? And we try and think about that while we're doing our assessment. Okay, so additional factors are saliva dentition, comorbidities, weight loss, medications, and also the fluctuations in presentation, which we do see in MS. We'll do an oromotor assessment, which assesses the strength and coordination of the anatomical structures in relation to the cranial nerves. And we do a bedside swallow assessment, which is observing the patient eating and drinking, sometimes with palpation, so feeling the throat, feeling the swallow, or listening with auscultation. Sometimes we do diaries over a few weeks to get a clear picture of what the person is eating and drinking and what they might be struggling with. And if we still can't understand what's going on, we might send someone for a VFSS, which is a video fluoroscopy, or a FEES, which is a fiber optic endoscopic evaluation of swallowing. Not easy words to say. So the first one is an X-ray of the swallowing, and we use barium and different modified textures to see how it goes down the throat. And we're also able to see down to the esophagus on our AP view, which is helpful as well. And the FEES is a camera, as you can see on the third picture to the right of the screen. That's what the FEES looks like. So intervention and guidance. It involves firstly trying to address any comorbidities, especially things like reflux. If we can get onto reflux and manage that appropriately, then we can really get a feel for the presence and severity of the oropharyngeal dysphagia. We might look at saliva and secretions. We might try and help someone with antibiotics if they've got a chest infection to try and get over that. Or we might make an onward referral to ENT, gastroenterology, neurology, OT, physio. We can do diet and fluid modification to help with the dysphagia. We definitely do compensatory strategies, and this is probably what we do the most. So these might be simple things like posture, small amounts, small sips, taking time, chewing well, reducing distractions, and considering the impact of fatigue and anxiety with our MS patients. We might try swallow rehabilitation and therapy exercises. We usually only recommend these after they've been for an instrumental assessment like video fluoroscopy or FEES. This is just because when we do those types of assessments, we can really see which exercises and rehabilitation exercises are going to possibly improve. Sometimes we like to try and improve the breathing and the cough reflex with EMST. There's a growing base of evidence for this, which is wonderful. Probably we can chat a little bit more about that later during the discussion. We might discuss alternative feeding with the patient and their family, their GP and the dietitian. And we often set up risk feeding, which is otherwise known as eating and drinking with acknowledged risk, if that's appropriate, with risk reducing recommendations in place. We can also discuss end-of-life care and support with patient and their family. So this is a case study as a 76-year-old male. He's diagnosed with relapsing remitting MS at 46 years of age. He's now 76. He was initially referred in 2019 and then re-referred and seen intermittently from 2021 to present. He has a long-term history of coughing and choking episodes, usually at mealtimes, but not just at mealtimes. He coughs at other times as well. He has throat clearing consistently and secretions. He takes medications for blood pressure, diabetes, and antidepressants. When he was visited by us, we did a bedside swallow examination, which included a reflux symptom scale, which is like a screener that we do for reflux. If the person's showing signs of having reflux but hasn't been diagnosed with it yet. So he scored very highly on that. We completed coughing diaries, which showed what he was reporting, which was coughing across consistencies of food and drink, which is quite unusual, and also coughing when he wasn't eating and drinking. So it wasn't like a true dysphagia where you're thinking, okay, it's this texture or this type of a drink and we can fix it in this way. There was something else going on there. So we decided to start him on reflux medication, PPIs, and we referred him for video fluoroscopy. So he went for a video fluoroscopy in December 2021 at Epsom. He was diagnosed with a mild motor sensory oropharyngeal dysphagia, which is consistent with his diagnosis. He had good oral preparation of solids, but poor oral tongue propulsion, which means pushing the food and drink back, with disorganized repetitive tongue motion and bolus escape. That means that there was food or drink escaping to the back of the throat before he had triggered a swallow, which means that the little flap that closes over the airway when you swallow didn't have enough time to move into position, and some of the drink fell down. So you can see here on the Rosenbeck aspiration scale, he was okay with a sip of thin fluids, 5 mils. as soon as he had just a normal sip, which is obviously more than 5 mils, the material entered his airway, remained above the vocal cords, and was ejected. So he must have coughed. Same thing when he had continuous sips. And then when he went to level 2, it was a little worse. Nothing went right into his airway, and thankfully he had a really good cough reflex. So we weren't too concerned about that, although that doesn't look good because it is going into his airway. It wasn't going past the vocal cords, and he was able to expel what had gone into the airway afterwards by either doing a clearing swallow or coughing. So some of the choking episodes were thought to be due to reflux and possibly laryngospasm. So next slide, please. We recommended a normal diet with added moisture and avoiding any high-risk foods, as these were the ones that he was reporting, and we were seeing in the diaries that he was coughing often on. We recommended small sips of thin fluids, so that's to avoid it entering the airway. No continuous drinking, robust treatment of reflux, and consistent taking of those medications, which he hadn't been doing in the past. But, you know, after our initial consultation with him, he had been doing that consistently and reported that it had really helped. So that's good. We referred to ENT. He was reporting sneezing and nosebleeds. And we provided some advice around reflux and relaxation and breathing through laryngospasm. We also spoke a lot about mouth cares in case saliva is aspirated. So doing the mouth cares regularly is done to aim to reduce the risk of aspirating any bacteria. And we managed to make sure there was follow-up with physio and, of course, our MS nurse. So the outcome was quite good. The patient reported a reduction in episodes of choking when using these strategies and when taking his reflux medications consistently. So it was a good outcome, really, because I don't think he would have wanted to modify his diet or fluids. So he wouldn't be someone who would like to trial thickener or take any of the other foods out of his diet. So by doing these compensatory strategies and managing his reflux, this was a really good way of sort of meeting him halfway to reduce the risk, really. Okay, thank you.
So thank you for two excellent talks. There is the potential to ask questions using the Q&A section, and if people could do that. There's a question about cough assist and when to refer for assessment. Jodie, do you want to talk about that?
Yeah, I think, thank you very much for that question. I think it's a question that does come up a lot and does cause a lot of anxiety. And I just want to recognise that first of all. And that's the reason why I presented the case study B. So, this gentleman had a peak cough flow at best of 50 litres per minute, which is like pretty low. And we at the time couldn't get, because it was during the pandemic, basically couldn't get referral for cough assist for him. And he is managing really well with the lung volume recruitment bag, good positioning, and regular positioning and better spasticity management. And he doesn't want to go for a cough assist. So I just wanted to make that point. I think there's a lot of anxiety about referral to cough assist because I recognise it's very different in different areas of the country. But I just think while you're in that, trying to get a referral for cough assessment, there are many other positive things that you can do. Posture, positioning, spasticity management have an awful lot of impacts on reducing the restriction on the chest wall and the ability for that person to take a deep breath. And the lung volume recruitment bags, and I've got one with me here if anyone wants to see it. I can kind of show you.
Yeah, please.
In a moment. I can do that now if you want.
Yeah.
Or yeah. So I've got lung volume recruit, and I will explain about where to refer to cough assist, haven't I? So this is a lung volume recruitment bag. It basically is it's like a rebreathe bag, but it's not for resuscitation. And they usually come with a little filter here. You can get them on NHS supplies. They cost £98 now. They've gone up in price, from £28, but you can still get them on an NHS supplies. And this is where I order mine from. And you can either use them with a face mask, or the right way around, or a set of nose clips and a mouthpiece. What that does is, as the person takes a deep breath in, you're topping that breath up with a big breath. The consensus document so that's basically what it looks like, and it's really simple to use, and there are very few risks. The biggest risk is that you will be ineffective. If they haven't got good bulbar function, they're unlikely to cope with this. That's the only caveat I would say. And then a cough assist might be, I don't know, Sheridan, if you've got any comments on cough assist and bulbar function.
Not so much on cough assist. Yeah, I mean, bulbar function is something that is a very good sign of that someone's going to be having a swallowing problem, but not in terms of cough assist. No.
Okay. So, so I've got an annoying piece of hair since I've moved my. So referral to cough assist is usually done to your specialist respiratory centres. So it's worthwhile contacting your local respiratory team to ask for their advice, whether they accept a referral for someone with MS, because they usually will say they don't fit their criteria because they haven't got inspiratory muscle disease. However, it's worth inquiring with them, and it will vary from area to area. Build friendships with your local respiratory physiotherapists and physio team, and they might be able to help support you with navigating, training and purchase of, but it does vary from place to place. But I just wanted to raise the point, it is challenging. There aren't clear pathways, but there are some areas of the country where there are better pathways, where those good pathways have been formed, and where there is clear cough assist pathway where there isn't in your area. Deep breathing exercises, posture positioning, and thinking about introducing a long volume recruitment bag can help.
So I'm going to butt in with both of you, and there's a question about using mucolytics for people who are having difficulty with secretions, and then the other thing would be anticholinergics for people with too many secretions. Sheridan and Jodie?
Shall I get Sheridan? Do you want to answer that? I did pop that up as a slide to recognise that that's obviously something we would consider.
Yeah, I think from a speech and language perspective, really, we again use more compensatory strategies, or we might do some oromotor exercises to help with saliva. We might also recommend natural remedies like, increasing your water intake or some other suggestions that we might have. But in terms of medications or anything like that, that's sort of not something that we recommend. We say discuss with GP if you want to use medications or anything else,
or even your neurologist. We're cautious about them because we're worried about the cognitive side effects and about constipating our patients. And we'll occasionally do it, and for people with severe problems, we'll sometimes use Botox. What about mucolytics for cough problems, Jodie?
Again, that's something that I would kind of discuss if that was a concern with a respiratory physiotherapy colleague, as I'm not a respiratory physiotherapist, and with a GP. I would also look at posture positioning and long volume recruitment bag to help, or breathing exercises to help stimulate a cough. But if they have got very thick secretions and it's difficult for them to clear, then yeah, it's something that's a multidisciplinary team discussion with the experts, really.
Jodie, there's a question about EMST, expiratory muscle strength training. Could you talk us through that, please?
I'm going to quickly answer, then get Sheridan to answer, because I know it's an area that she's got a little bit more interest in, or not a bit more experience and passion with. Often it's something that the speech and language therapists will prescribe once they've identified that there's particularly issues there. There is a small amount of evidence it's helpful for earlier on, but not when you're kind of dealing with peak cough flows of 50 and below. But I'll let Sheridan answer.
Yeah, agreed. There's a growing evidence base in all, Parkinson's and in stroke, head and neck cancer, MND, and including MS. They've found that it does increase maximal expiratory pressure and peak expiratory flow. The maximal voluntary cough is only improved in subjects with a moderate level of disability when the MS group was divided into mild and moderate disability levels. That's sort of the evidence that we're looking at the moment. So I think they're starting to see that it's making a bit of a difference in the MS population as well. So that's interesting.
I just think it's one of those questions that we're going to be asked more and more, and people with MS who want to know what they can do to prehab themselves will want to know, is this worth me investing in? And I suppose is that, what the answer to someone who asks that
I think
question?
so. I just think the evidence base is not there yet.
Yeah.
You know, Parkinson's have had a lot of, you know, evidence and research, so that's great. And that started there, and now they're just sort of, you know, moving this therapy into other areas and seeing how it goes. And so far, it's been doing quite well.
Can I put in a word for the chin tuck method? And I don't know if you want to teach people about that. I often find that it's very helpful in clinic.
Mm-hmm. Yeah, so the chin tuck method is just when you're eating or drinking. So you either have a sip of the drink or put the food into your mouth, and as you go to swallow, you just do a little chin tuck like that, and then swallow the food or drink. And basically that's just because the chin and the positioning moves everything into a place that protects the airway. And it doesn't always work, but it's not going to adversely affect anything. So sometimes we get people to do it in video fluoroscopy and it doesn't help, but it's not going to hurt or do anything, you know, adverse. So worth a try.
Some of my patients find that it's very helpful as a kind of rescue technique. If they're having soup and it's not going down well, they can kind of go into that method and they find it quite helpful. And we'll teach them waiting for the speech therapy assessment.
Yeah, definitely.
How often do you find that breathing problems and speech problems are independent? And how often do you find that they're all linked together?
Oh, definitely linked together. Almost, yeah. I mean, speech problems, if you're having breathing issues, you're definitely going to have speech problems. And I guess the same for swallowing. If you can't produce a strong cough, and you're having other weaknesses, then it's going to make it difficult to, you know, get any of the food and drink that's gone down into the airway back out again.
Yeah, I would agree that I think you should be concerned if you're visiting someone and they've got, you know, they're difficult to hear, they're weak, and often people don't report this as a concern of theirs. They're often, I find that they're concerned about something else, but you might notice it, and it's time to kind of start some early intervention and start thinking about referring other members of the team in if they haven't seen anyone recently.
Definitely.
Discussions around gastrostomy. How keen are people? How resistant are them? What's your experience with dealing with it?
I usually, at the beginning stages of, you know, going to meet up with someone and assessing their swallowing, I probably wouldn't broach the topic unless they had queries about where the dysphagia might go. If they're asking, you know, what's the prognosis, but you never really know what the prognosis is. So it's sort of something that I would only bring up if it was sort of thought that the dysphagia was getting so severe that sort of hydration or nutritional needs are not going to be met or not be met in the, you know, foreseeable future, and would be a joint discussion with neurology, dietitians, GP as well. Yeah.
And kind of end of life, often, you know, speech, swallowing, breathing are some of the things that may be the terminal events or the problems that happen later on in patients' career, you know, the disease paths. How often are you dealing with those very difficult discussions, Jodie and Sheridan?
I think that we have therapists interested in MS have like a MS self-report questionnaire, and we had a lot of discussion on, and that can be used where a person with MS can kind of identify what they're worried about, and we had a lot of discussion about whether to put end of life conversations on there. So for some people that conversation can happen quite a lot earlier on. I think it's something that it's depending on your experience and where, and some people they might bring up, I think, so it's not something I would sort of say early on, but because it's in a self-report questionnaire, it's there if anyone has got any questions to ask about. So I don't know if I've answered the question. It really does depend on the situation, whether that person's ready for that conversation, but I wouldn't be afraid to have an early conversation if it was brought up by them.
There is time for any more questions if anyone in the audience wants to add, but in the meantime, carry on, Sheridan.
Yeah, I agree everything that Jodie said. I mean, maybe looking at the respect form or similar to bring up a conversation like that. I've recently had a patient who's fluctuating very significantly between just seeming like she can't eat and drink anything to then, you know, a few days later, everything seems like it's gone back to normal again. And her family have asked to at least meet with, you know, Princess Alice Hospice, and we're arranging that because they feel that, you know, they want her to be able to talk to the people that are going to be looking after her at end of life. So I mean, you know, Princess Alice seemed happy to come and do that initial consultation early. So yeah, I think that's a good thing for them to meet as well, even though it's probably not at that stage yet, although it could be very soon.
And
I mean, I do.
Carry on.
Sorry, I was just saying, I just concur. I do quite early referrals to the hospice for symptom help with symptom management for people who you know, just to live well and stuff. So
Absolutely. How much of a challenge do you find it with patients with cognitive problems who you know, will keep eating when it's dangerous or won't manage the techniques, or because their cognition is interfering, and how do you work around that, particularly with communication, Sheridan?
Yeah, it's a real challenge, and I personally feel like in this population, it seems as though there's often someone who might be living on their own, who mostly has capacity, but then is not always remembering things, you know, in terms of their eating or drinking, or they might be following recommendations one day but then not the next day, and it's really, really difficult. I try and get, you know, OTs in to help with their positioning and to make, you know, the chair, if it's an armchair that they're eating in, so they don't have to get up and go and eat at a table, to make sure that the armchair is, you know, the perfect sort of positioning for them to eat in. I also contact the care agency and tell them, you know, what's going on, of course, with the person's permission, so that they can check in as well and just make sure that the person is, I guess, trying to follow the recommendations or able to follow the recommendations, and also discussing with any family members or friends who come in to visit as well. So I guess just so everyone's on board.
That's I guess where risk feeding comes in as well, and autonomy around that. If someone has cognitive problems, giving them what they're wanting, as long as it's reasonably safe, is sometimes the least bad option, as long as everyone's agreed.
You're 100% right, because often the person might, you know, say they understand and be able to tell you, well, feedback to you what the risks are, but then they don't want to use the thickener. So when you leave, they don't want to use it. They just go back to not using it. And so in that case, of course, yeah, we set up risk feeding. And if they don't have capacity, then of course we involve the POA and the family and friends to get that set up.
I think that we're running out of time. Jodie, Sheridan, final comments. It's been an absolutely fantastic talk. I think really, really practical and helpful, and a lot of insight for people with very advanced disease. Jodie?
I would say if you're thinking like cough assist, I'm struggling, don't underestimate the value of good positioning, good posture, and encouraging some breathing exercises. There's quite a lot that you can do while you're trying to navigate the rest of it. So don't underestimate the value of that.
And make friends 100%. With your respiratory team.
Sorry?
And make friends with your respiratory
team. Make friends with your respiratory team, for sure. Yeah.
I 100% agree with that. And maybe, you know, if you can get them to slow down or have smaller mouthfuls, from my perspective, as well as the positioning, that typically really, really helps things, like the case study that we saw as well.
So be breathing aware, be swallowing aware, do the simple things, look after their overall medical problems before going in for big interventions, and then knowing when to escalate if necessary.
Absolutely.
Early monitoring, peak cough flow, early monitoring from the point of diagnosis, if you can.
And teaching them to sing early.
Yeah.
Brilliant.
Sing, breathe.
It's been a fun session, and it's been an incredibly helpful and interesting and learning session for me in particular. I really thank you very, very much.